Hi, I'm Dr. Ramakrishnan, Director of Critical Care Services at Apollo Hospitals, Chennai. And this module will focus on lower respiratory infections, particularly community acquired pneumonia. When we think of respiratory infections, the most common ones are probably upper respiratory infections that present with sore throat, nasal congestion. But we will focus only on the lower respiratory tract infections, of which bronchitis is one, but we will focus on community acquired pneumonia. And pneumonia is actually acute infection of pulmonary parenchyma. And when I say community acquired, it's outside the healthcare setting. Community acquired pneumonia is a significant public health concern. And the World Health Organization estimates that it's the most common infectious disease cause for death in the world. And almost about 3.5 million deaths could be accounted for related to community-acquired pneumonia. And it's probably the third most common cause of deaths overall in the world. Of the patients who come in with community-acquired pneumonia, almost about 21% of them may require ICU admissions, and 1/4 of them, almost about 25 to 26%, may require to be on mechanical ventilator support. And the mortality from severe community-acquired pneumonia could be from 25 to 50%. The incidence of community-acquired pneumonia increases with age. So as you can see from this graph, it's much more common in the over 60s and the over 70s than the younger age group in the 20s and 30s. When we think of risk factors for community-acquired pneumonia, advancing age is the most important risk factor that we think about. And remember that older people may have atypical presentation, which may delay the diagnosis. For example, they may not even mount a fever response or high WBC count. We need to keep in mind other comorbidities about which we will talk a little bit later. But remember, COPD, chronic obstructive pulmonary disease, is one major comorbidity that often presents with respiratory-related exacerbations, which could be due to a bronchitis. There may not be a parenchymal involvement. Bronchitis could trigger a COPD exacerbation. But if there is parenchymal involvement, think about the community-acquired pneumonia. Smoking and alcohol abuse are other risk factors not to be ignored. And also keep in mind the living conditions. Sometimes lower economic group living conditions may increase the risk of developing pneumonia, and also exposure to any kind of environmental toxins. When a patient presents with symptoms that want you to make a diagnosis of pneumonia, it's often a triad that we look for. Number one, patients presenting with fever or chills, and subsequently when you do a CBC, you may find that the patient has leukocytosis. Number two, signs or symptoms localized to the respiratory system. Here, remember that you need to distinguish between upper respiratory symptoms and lower respiratory symptoms. When patients have upper respiratory infection, often they may just have stuffiness of the nose or sore throat. With lower respiratory symptoms, you would hear that the patient has a cough that is productive. They may complain of pleuritic chest pain, breathlessness, or any of the other symptoms related to the lower respiratory system. If you subsequently do a chest X-ray and you find that there is a new or changing infiltrate, that is also a clue towards this triad of making the diagnosis of community-acquired pneumonia. Once again, I want to reiterate that we need to distinguish between upper respiratory infections, which are more often viral and therefore do not require initiation of antimicrobial therapy. And I think that's very, very important because abuse of antibiotics in upper respiratory infections is one of probably the most important reasons for developing resistance when patients may subsequently need it for other reasons. Once you've made a diagnosis of pneumonia, does every patient need to be admitted? Probably not. And that's where using various severity scores seems to be of value. The intention is not to go through every single severity score, but I will show a couple of them that may be very helpful to guide whether a patient needs to be admitted. And one such is this CURB 65 scoring, where we look for, is the patient confused? Is the patient's urea level elevated? And if you're using millimoles, it's more than 7 millimoles, or it is more than 20 milligrams per deciliter. Is the patient tachypnic? By that, is the respiratory rate more than 30? Is the patient hypotensive, where you are looking for systolic blood pressure less than 90 or a diastolic blood pressure less than 60 millimeters of mercury? And of course, we've been talking about advancing age. So here is the age more than 65. Now, each of these scores 1 point. So the minimum is 0 and the maximum is 5. And if you have a patient who has a low score, then you probably can manage the patient at home if it is 0 or 1. If the score is moderate, which is 2, the patient may need to be admitted to the hospital, but probably not in a monitored environment or in an ICU. But if the patient has a high score from 3 to 5, you need to assess the patient to probably be closely observed in a monitored environment, such as an intensive care unit or a high dependency unit, where you may admit and take care of the patient. The other score that is often used is a SMART COP. It's more a mnemonic that we use, looking at systolic blood pressure if it is less than 90. Is there a multilobar involvement in the chest X-ray? Is the patient having hypoalbuminemia? Is the albumin level less than 3.5? Is the patient tachypnic, respiratory rate more than 30? Is the patient tachycardic, where the heart rate is more than 125? And as you can see, each one scores 1 point. And also look for confusion, oxygen saturation, whether it is less than 90%. And if you can do a blood gas, is the pH less than 7.35? So based on the scoring, you can classify the patient as low risk, moderate risk, or high risk, and admit them or manage them on an outpatient basis as appropriate. Once you have made a diagnosis of possible pneumonia, you want to investigate this further, and the investigations could broadly be classified as non-invasive and invasive. In the non-invasive tests, we often do blood tests. Most importantly, as we already mentioned, complete blood count, urea, creatinine are all tests that we run. Biomarkers such as procalcitonin are increasingly being used. Microbiological samples, including patients' sputum, which they may be coughing, nasal swabs, which now we are increasingly using in the COVID-19 situation, endotracheal aspirate if the patient is already intubated and in the ICU, and blood cultures, of course. Now, the yield of blood cultures and sputum may not be very high, but some of these can be very specific and help you guiding further therapy. Radiologically, we often do chest X-ray, but in certain cases, we may elect to proceed with a CT scan, particularly subsequently in non-resolving pneumonias. Invasive tests are often limited. We don't do them routinely, but if necessary and if suspected, you may need to do bronchoscopy or a lung biopsy if you're suspecting malignancy or something different. It's important to understand what are the common organisms that cause pneumonia. What we call typical pneumonia is classically we think about Streptococcus pneumoniae, Haemophilus influenza, Moraxella. Occasionally we could see Staph aureus, group A streptococci, and also aerobic gram-negative bacilli. These are the common, probably bacterial causes for community-acquired pneumonia. We also see what we call atypical pneumonia, which is again extremely common. And this could include Legionella, Mycoplasma, Chlamydia, and also Coxiella burnetii. Now, we need not always have bacterial causes of pneumonia. Viral pneumonias are also very, very common. And right now, I'm recording this module at a time when we are amidst the COVID-19 pandemic, which is a viral pneumonia that we are increasingly seeing. So keep in mind that influenza A and B can cause pneumonia, rhinoviruses, adenoviruses, respiratory syncytial virus or RSV, human metapneumovirus, coronavirus, which we are seeing now, and human Boca viruses. So there is a wide variety of organisms that could potentially be causing the community-acquired pneumonia. The incidence of pneumococcus is decreasing due to widespread immunization. And once again, we are right now at a time when we are stressing the importance of immunization, adult immunizations, particularly to prevent pneumonia or any other kind of infections. So influenza vaccination is done routinely annually. Pneumococcal vaccination is recommended for specific target groups. And right now, we are in the process of administering COVID vaccination. So immunization has certainly reduced the incidence of pneumococcus, and we seem to be having increasingly viral pneumonias. More and more number of respiratory viruses are being identified, probably related to better molecular diagnosis. But this is important because viral pneumonias do not routinely need to be treated with antibiotics. If indeed you are suspecting a bacterial pneumonia and want to initiate antibiotics, it is important to administer the antibiotics early, particularly in the group of patients with pneumonia whom you are considering hospitalization, whom are presenting to the emergency room. It's important to assess early and initiate antibiotics early. As you can see, if it is administered within 4 to 8 hours of hospital arrival, you can significantly reduce the mortality from anywhere from 5 to 43% relative reduction in mortality has been shown in different studies. And each hour of delay in antibiotic administration can lower the survival by approximately 8%, particularly in patients with severe pneumonia and what we call septic shock, when they are significantly hypotensive. And in septic shock, it's all the more important to be administering the antibiotic as soon as possible. And guidelines are in fact recommending that this administration of antibiotics in patients with severe septic shock should happen within an hour of recognition of sepsis, and what we could refer to as the golden hour. Once you have decided on initiating antibiotic therapy, it's important to decide on what would be the appropriate antibiotic to use. In a patient whom you're going to manage on an outpatient basis without hospitalization, the ones that you have recognized as low severity or low risk, you need to initiate antibiotics such as amoxicillin or doxycycline or a macrolide such as azithromycin if they don't have any comorbidities or any risk factors for organisms such as MRSA or Pseudomonas aeruginosa. If the patient does have comorbidities, it is recommended that you initiate combination therapy. And this combination therapy could be amoxicillin clavulanate or a cephalosporin, along with a macrolide or doxycycline to cover for the atypical organisms that we talked about. Or you could initiate a monotherapy with respiratory fluoroquinolone. We have been referring to the term comorbidities. What does that include? The comorbidities could include chronic heart conditions such as heart failure, chronic lung diseases such as COPD or interstitial lung diseases, pulmonary fibrosis, chronic liver diseases, chronic kidney disease, including patients who are on dialysis, diabetes mellitus, which is extremely common, alcoholism, malignancy, or asplenia. Now, patients with comorbidities, as we already mentioned, should receive broad-spectrum treatment for a few reasons. One, they're more vulnerable to poor outcomes if the initial antibiotic regimen is inadequate. So therefore, they need to be covered broadly in case it's not an organism that you have initially suspected. And also, they could have risk factors for antibiotic resistance because some of these patients with chronic diseases could have had contact with the healthcare system. By that, I mean they could have been hospitalized or they may have been exposed to other antibiotic therapy recently, leading to resistance. So you've decided on the antibiotics, you've initiated it. How long would you give it? That really needs to be guided by assessment of the clinical stability on how the patient is improving, such as resolution of any abnormalities of the vital sign. Is the patient able to eat normally? Is the mentation normal? Overall, is the patient getting better? Like the respiratory rate getting better, heart rate getting better, no fever. All of those need to be assessed. However, antibiotic therapy for community-acquired pneumonia should be no less than 5 days, and it's usually about 5 to 7 days. And it's also important to understand that there is no routine recommendation for a follow-up chest X-ray after completion of the antibiotics for 5 to 7 days. If you have given antibiotics and you feel that the patient is not improving, what could be the causes for the treatment failure? Number one, it could be incorrect diagnosis. It may not have been a community-acquired pneumonia. It could have been something to do with worsening heart failure. It could have been a pulmonary embolism. It could be a neoplasm. It could have been sarcoidosis, some kind of drug reaction, hemorrhage. Any of these conditions could mimic a pneumonia. And so an incorrect diagnosis may make you not see the kind of response that you would like to see when you are initiating and completing the antibiotic therapy. It could be other factors relating to host, drug, or the pathogen. As you can see here, if there is a local factor, if there is an obstruction in the bronchus, that could make you have a non-resolving pneumonia. If there is inadequate host response, or if there's any kind of a complication, particularly if you're seeing a secondary infection or an empyema, then you may encounter a non-resolving pneumonia. It could also be drug-related factors, for example, wrong drug selection or giving it in the wrong route, not complying with the antibiotics appropriately, or having any kind of adverse drug reaction, and not to forget giving inadequate dosage, which may happen at times. It could also be a drug-resistant organism or a pathogen that you've not suspected and therefore may not be responding to the antibiotic you have given. In conclusion, community-acquired pneumonia is one of the leading causes of death amongst infectious disease causes, and early recognition and management can significantly improve the outcome. Using some kind of a clinical risk assessment model to assist in your decision on whether to manage the patient on an outpatient basis or admit them to a hospital in the floor or in the ICU would be important. Obtaining cultures, appropriate cultures of sputum and blood before administering the antibiotics would be essential. And it has been clearly shown, particularly in patients with severe sepsis, septic shock, early administration of antibiotics can impact the outcome, and remember the golden hour and administer the antibiotic as soon as possible. I can't stress enough, and therefore wanted to make this my last comment. Do not use or do not initiate antibiotic therapy for upper respiratory infections that are viral in origin, and that is probably one of the most important reasons why antimicrobial resistance can develop. Use antibiotics only when appropriate. I hope you found this session on community-acquired pneumonia and respiratory infections useful. And if there is one take-home message that I would like to stress once again, it is using antimicrobial therapy wisely and appropriately, and avoid any kind of inappropriate usage.